Yes, we can see them.
So I can start. Sorry for the delay. I have a flu, but it's okay. I will try. So last time we was looking at chest imaging, especially for chest radiograph interpretation. But I wanted just today to start by abdominal imaging, overview of abdominal imaging, and we'll see how to interpret plain abdominal X-ray. And we'll see some exercise, some examples, cases, and done. So for the anatomy, I think the surface anatomy of the abdomen, you know it. You know the abdomen from the overview. It's divided into 9 regions where you have epigastric region, you have right epicondyle, left epicondyle, you have umbilical region, you have right lumbar or flank region and left lumbar region. We have right iliac and left iliac region and hypochondrium. This is, and by seeing this, we know which organs, abdominal organs, we can consider in each of these regions. So, as I hope you know what is acute abdomen. By definition, acute abdomen is a sudden or severe abdominal pain caused by there are different causes, many different causes of this sudden or severe abdominal pain. But those causes now, we can consider them according to those different 9 regions we have seen of the abdomen. When the pain is localized, it can be localized on right upper quadrant or right lower quadrant or left upper quadrant or left lower quadrant. It can be localized on epigastrium, on hypochondrium, or even umbilical regions. Sometimes you have diffuse pains where it is not localized. And now, when you have either it is localized pain or diffuse pain, abdominal pain, now as a doctor, medical doctor, you can think of which imaging modality can use to diagnose the cause of that pain. In most of the cases, we use plain abdominal X-ray when the pain is diffuse, okay? But when it is localized, in most of the cases, we use ultrasound or CT or even fluoroscopy. But generally, plain abdominal X-ray is used when the pain is diffuse, okay? So as I said, acute abdomen, by definition, is the syndrome with clinical symptoms linked to visceral distension or ischemia, or in the case of peritonitis. And generally, those are the most common causes. There is a study that has been done long ago, but it still has value today, where they try to show us the most common causes of acute abdomen or abdominal pain. And in that study, appendicitis was the most common with 28% appendicitis, followed by cholecystitis with 10%, and small bowel obstruction, 4%. Gynecologic causes, they are different. It can be ovarian cysts, It can be ovarian torsion. It can be ovarian abscesses. It can be ectopic pregnancy. There are many. They represent 4%. Pancreatitis, 3% in that study. Renal colic, 3%. Peptic ulcer, those are the most common causes, 2%. Pain caused by cancer, any cancer, GIT or abdominal cancer, 2%. Diverticulitis, 2%. And 34% in that study were no cause was found, okay? And even today, some patient can come with abdominal pain, and when you do your physical examination or clinical examination or even imaging, you don't find anything, any cause. So this is a diagram trying to show different differentials when you have a localized pain of abdomen. When the pain is in right up hypochondrium, you can think of gallstone in the case of cholelithiasis. You can think of cholangitis. You can think of hepatitis, liver abscess, cardiac cause. When there's a cardiac disease, you can sometimes feel the pain on the right side, and lung causes at the base of the lung, on the right side. That is right hypochondrium. And the left hypochondrium, there are no many organs there. You can think of spleen or splenic abscess. You can think of acute splenomegaly or splenic rupture in case of trauma or especially. And when the pain is now when there is epigastric lesion pain, the most probable causes can be esophagitis, peptic ulcer, perforated ulcer, or even pancreatitis. Remember, the pancreas anatomically is behind the stomach. In the case of right lumbar region or right flank region, you can think of urinary colic. You can think of pyelonephritis. The same as for the left lumbar or the left flank region. The same is gastrecolic colic, the ureter, and pyelonephritis. Those are the most probable differential diagnosis. For umbilical region, you can think of appendicitis. Remember, the appendix can be localized at different, it can be even in right hypochondrium. They didn't mention that appendicitis, but you can even feel the pain at right hypochondrial region. But especially for umbilical, you can think of appendicitis, mesenteric causes, mesenteric lymphadenopathy, lymphadenitis, Meckel diverticulitis, and even lymphoma, especially lymphoma involving the small bowel. And for the right iliac, now appendicitis is normally the proper region for the appendicitis. Crohn's disease, especially that's involving the ileum and the colon, ascending colon, especially. You can think of cecum obstruction, You can think of ovarian cysts, as I told you, gynecologic causes, ectopic pregnancy, and even hernia. For the left, that was right iliac fossa. For the left iliac region now, you can think of diverticulitis, involving especially the descending colon. Ulcerative colitis, still involving the descending colon. Those are the most common location of these diseases. Constipation, ovarian cyst, as on the contralateral side, and even hernia. And for the hypogastric region, you think of testicular torsion, and think of urinary retention. You are not, when abdominal pain film or ultrasound are not clear, or for patients who are obese. Remember, I told you that obesity can be even an indication for CT, self obesity. So, as now we have seen the list of different causes of abdominal pain, now when you have like right lower quadrant pain, because it's localized, the first imaging modality you have to use is ultrasound normally. And after ultrasound, when ultrasound is not clear, the findings are not clear, you go for CT scan. And remember, if I say right lower quadrant pain, it's like right iliac fossa. You just the most common cause of that pain, you have to think first is about appendicitis. And now the rest comes after. Normally, when patient comes, a female or male patient has right iliac fossa pain, the first thing you think you have to consider is appendicitis. Okay, that's commonly what we think about. When it is about left lower quadrant pain, in most of the case, ultrasound cannot help, because remember what is there in left lower quadrant pain region. There's just colon, descending colon. What else? For females, maybe ovaries and everything. In most of the cases, ultrasound cannot help, because the first diagnosis you have to think about is about diverticulitis. For diffuse abdominal pain, as I told you, we normally start by plain abdominal X-ray, and when it is not clear, we go for CT scan. And in most of the cases, the cause of that diffuse abdominal pain is bowel obstruction. and bowel obstruction can be diagnosed by plain abdominal X-ray normally. When the pain is Now hepatic flexure, and now transverse colon. It make a U. It's like it's not horizontal or transverse as you think, but anatomically it comes down a bit and goes up like this. That's the transverse colon and splenic flexure, and descending colon here, sigmoid and rectum at this level in the pelvis. So number 8 here, is it 6? Iliac bone. And number 7, if I see very well, this is sacrum, can you see? And sacroiliac joints bilaterally, right side and the left side. Remember, this is always the right side, this is left side. Sacroiliac joint, because this is ilium or iliac bone, but this is sacrum. Now sacroiliac joint and sacroiliac joint. You remember, you can see how you see the spinous processes. You can see them the same line as what you have seen on chest. And yeah, the rest. This is now the femoral head. So and again, you can even see number 13. I think they wanted to show the major psoas muscle. Can you see the major psoas muscle? This is right side major psoas muscle and the left major psoas muscle. They're very well outlined. Can see them. So who can tell me the structures you are able to see here?
Enlarged colon.
You see the enlarged colon. That's one. Another one.
Serrated small.
There is a small bowel.
Yeah.
Another structure, please. Any structure as you have seen on the previous. You remember you have seen many structures here, but what are you able to see here?
Please.
I see the river.
Yes, you can see the river here. The shadow of the river here. What else? What else, please? Over sharp.
Spleen.
The spleen. I don't see it. Olambe, I don't see the spleen. Where is it? I don't see the spleen.
Pelvic bones.
Pelvic bones, like iliac bone, like sacrum, iliac, sacroiliac joint here on the right side, but left side is covered by the bowel loops. You see the head of the femurs, the pelvic. How do you call this?
Pelvic inlet.
Pelvic inlet. So there are some people who have said that they can see the colon and the small bowel. I don't know if they can differentiate them from here. Can you?
No.
You can't.
I can try.
Yeah, try it. Tell me.
Yes, doctor, the large intestine is the one which is, if we see on the right iliac bone,
Uh-huh.
this one
Uh-huh.
which is goes up, and we see them in this splenic structure of the large one and come down, and the remaining one which is making like a zigzag are a small bowel.
Okay, that's what you are going to see. By the way, that's the reason for this lecture of today. Like for information, but sorry for going into details before we see how to differentiate them. All of these, you see, the dilated loops here, they are small bowels. And the colon
Okay.
is, sorry, all of these, they are small bowels, small intestines, the dilated one. The colon, you can even see the colon here and there, but the rest you can't see it. Maybe the rectum here, but these are the small bowel loops. But how to differentiate them, how to organize them, that's what you are going to see. Okay. So, as we have done for chest radiograph now, we have even, you remember, we have a system for chest. I want to remind you something. The same for chest radiograph. Remember, it started by the identification of the film of the patient, and secondly, the technical qualities of chest radiograph. You remember the 5 things you have to check for. Who can remind me? The 5 things in technical you have to check for. Collimation or centering.
Penetration.
What?
Inspiration. Inspiration.
Umuntu umwe wabivuga byose. Symmetry.
Yes, we have the coordination, we have penetration, we have a system, we have a symmetric or rotation, we have to check inspiration, and then angulation.
And then?
We check angulation.
So there are 5 before you go for analysis. So the same here for the same for abdominal X-ray, there is a system you have to check. The first one is about identification, the right film for the right person, identification. Number 2 is about techniques. But in techniques, we use what you call now ABCS. That is, those abbreviation ABCS. We see what is A, what is B, what is C, and the S. And you remember for chest radiograph, you said we do A, B, C, D, something. And now we made it easy and say we start by the mediastinum, we go to the lungs, bones and soft tissues. You remember that's the system now we agreed on to use in the rest of your life. Mediastinum, lungs, bones, and soft tissue. Here now for abdominal X-ray, plain abdominal X-ray, we use that ABCS, we receive. But when you use this, it's about technical details. We'll see what we see. We look at interventions, what has been done, systematic search for pathology. How do you systematically search for any disease and abnormal opacities? Now we'll see. Okay, but the same system, start by identification, you go for technical qualities, and you start now analyzing. So some people say that abdominal X-ray is a bit difficult, a bit harder to interpret than for chest radiograph. But that's what I was saying. The logic is say the same. As long as you have a system, the method of looking at them, either chest radiograph or abdominal X-ray, you should not miss anything, the important finding. But what the most important here is having a system, having a method. As for chest radiograph, remember, you have to follow a method. If you don't follow the method, you will miss. The same for abdominal X-ray, there is a method. There is a system you have to follow. So, as I have told you, the first thing, it's about demographics, it's about the identification of the patient or the film. Please check, identification is the same as for chest radiograph, the name, the age, gender, time, the date of examination, the time. Remember, you can do many different abdominal X-rays in a day. That's the reason why the time is, even which, was it in a supine position? Was it an upright position? Was it lateral decubitus? So that view, the view is part of the identification. The same for chest radiograph. Remember, when you are describing a film, you say this is a PA, this is an AP chest radiograph. The same here. Like this is abdominal radiograph. They say don't say X-ray. Normally we don't. It's not good to use X-ray. It's not an X-ray. It is radiograph, abdominal radiograph of Mr. or Mrs. X. In supine, we see in supine AP position, you see the view, the view or the position taken on this date, you know. So those are now, they want to show what you have to recall for identification of the film. Please remember and give it value, identification of the film of the patient. That's number one. In identification, you remember the name, date of birth, age. It's better to use age, a hospital number, the date of X-ray, the time of X-ray or radiograph. So those are important things you have always to check before you start interpretation. Number two, for chest radiograph, remember for chest radiograph, there are 5 things you have to check. That's technical now. For abdominal X-ray, there are only like 3 things. You check for penetration also, and for penetration, you should, the same, the effect is if it is over-penetrated, it changes the appearance, the quality of the image. If it is under-penetrated, it changes the quality. Under exposure, too white, over, too black. Okay, remember. Now, for plain abdominal X-ray, penetration is checked by looking at the spine. You should be able to look at spinal processes. For chest radiograph, remember, you just see or you faintly see the spine through the heart shadow. But here, you should be able to see the spinal processes. If you are able to see the spinal processes, that's a good penetration here for abdominal X-ray, abdominal radiograph. Field, it's about collimation now. They say a very good, well taken abdominal X-ray, you should see the diaphragm should be included. The diaphragm. For you not to miss the pneumoperitoneum. Remember, pneumoperitoneum, we see the free air under the diaphragm. And up to down to the ground. Don't miss any hernia. So the pelvic bone should be within the film so that you don't miss any pelvic pathology, especially hernia. And how do you check the symmetry? If there is no rotation, you should check the both sacroiliac joints and the spinous processes. You remember for chest, we used to measure the distance from the spinous processes and the medial end of clavicles. You remember both sides, left and right. You compare the distances. Here the same. From the sacroiliac joint to the spinous processes on the left, that distance should be compared to the same distance on the right side. That's how we check for the symmetry. So those are three things in technical you should check for before you go for analysis. Okay, it's simple. It's FPA. Penetration, you know how to check for. Collimation of field, please make sure the film includes the diaphragm because the cause of the abdominal pain can be pneumoperitoneum. Air, free air in the peritoneal cavity. And also remember that the pelvic bone should be included in the film so that you don't miss pelvic pathology, especially hernia, and check if there is no rotation by comparing the distances from the sacroiliac joint to the spinous process line. Okay, is it clear? Is it clear?
Yes.
Hello? Tell me if you can hear me.
Is it clear?
Okay, so let us continue. So like now, you remember that I told you we go for analysis, we go for ABCS. Okay, ABCS. What is A? A for abdominal X-ray, A is for adequacy, alignment, and apparatus. Remember this. For A, you check for adequacy, and adequacy, they want to say now it's a technique. By the way, you see if there is adequate penetration, like here, it's adequate because we're able to see the spinous processes. You check if there is no rotation. The distance from the spinous processes to the sacroiliac joint on the left side, compare with the right side. For me, there is no big difference. So meaning this is symmetrical. There was no rotation. And you check for the collimation. Like here, the collimation was not good, especially you have cut off the diaphragm. You are not able to see the diaphragm, meaning this is not a good quality of plain abdominal X-ray. Okay, so adequacy for A is for adequacy, alignments for there's no rotation, and apparatus. Is there any artifact? Remember, anything that was not supposed to be there, like on this second plain abdominal X-ray, you can see these surgical clips here. When they are there, it can either they can even help you to diagnose a disease, but also you have to mention in your report or interpretation that there are some apparatus or artifact or apparatus, anything that can orient even to the diagnosis. Okay, so that this is for A. So after identification, you go for A, adequacy. That is technical. Alignment, still part of the technical, and apparatus. Before you think of any disease. Okay, that's number one. Number B, it's about B. B, it's about bones and calcifications. Okay, remember that there's some normal calcification in the abdomen especially for the spine and aorta. Old people, some aorta have calcifications, and those calcifications are normal. But also you can see some abnormal calcifications, like gallstones, the stones in the gallbladder, pancreatic calcifications in the case of chronic pancreatitis, and when we see them, very common, and urinary tract stone, either in the kidney, you can see diagnosed on plain abdominal X-ray, or ureters, or even the bladder. You can still diagnose some calcification or stones or caliculi. So bones, when you say B, it's about bones and calcification. Please make sure you check the bones that are included in the film. Get the spine, check the spine is okay. It can even be the cause of the pain. Check the pelvic bones, okay? Check the ribs, the lower ribs. Remember, if you have to include the diaphragm, the lower ribs can be seen. Please check if they're normal, if there is no fracture. Check the pelvic bone, check the joint, no, not joint, bones, and calcification. Check the kidney. You remember, you can see the shadow of the kidney. Check, the pathway of the ureters, if there is no any calcification, and check also in the bladder. You can see the shadow of the bladder. The bladder is located in the pelvis. So B, it's about bones and calcifications, and C is about no. These are example of what you have to check on B. Like in this case, remember they have done maybe the abdominal X-ray. Don't miss any fracture. Like in this case, there was a femur neck fracture. Can you see? Don't miss it. Don't think you are just checking the abdominal organs and forget to check the bones. Don't miss any bone diseases. Like in this another case, it was about bone sclerosis. Can you see in Paget disease? The bones here in the pelvis, they are sclerosed. They are not normal bones, sclerosed, too much white, sclerosed. And in this one, don't miss any dislocation, something, that is now pubic diastasis. And you see how this pubic bone are separated. In case this is normally seen in the case of after delivery. After delivery, we can see this kind of dislocation, okay? So they wanted just to show you how you should not go, even if it is abdominal X-ray. Please remember, A, it's about adequacy, alignment, and apparatus. B, it's about bones and calcifications. And C is about joint and cartilage. For joint, especially cartilage, maybe it's part of its contains in joint. C is about they just mention cartilage so that it can be C, but it's for joints. Okay, please check if there is any joint problem. And remember, in this, it can be the joint in the spine between vertebral bodies. It can be the joint we have in the abdominal pain, abdominal X-ray. It's for the spine. It's for sacroiliac joints. Check if they are normal. And even for hip joints, those are hip joint, even these pubic joints. Please check them. Check them if they are normal. Okay. And yeah, and S now it's for soft tissues. You remember it's about A, B, C, S. It is very easy. A for adequacy, alignment, and apparatus. B, bones and calcifications. C is for cartilage and joints. And S is for soft tissues. Soft tissues, remember what you have seen. You are able to see the shadow of the liver, able to see the shadow of the spleen, you are able to see the shadows of the kidneys, be able to see the major psoas muscle, remember, even the intestines, and they are part of this S for soft tissue. Intestines, GIT, and even pelvic, like in the, remember the inner bladder can be seen. The shadow of the inner bladder when it is distended can be seen in the pelvis. So those are under S you should check for. So and for example, when for major psoas shadow, if there is absence, you are not able to see one of them. Remember, there are two on each side. If there is absence of psoas shadow, it can indicate any intra-abdominal or retroperitoneal fluid or disease like an abscess or ruptured abdominal aortic aneurysm or ascites. So absence of one of these soft tissue structures we are able to see can indicate the disease, can indicate which disease is about. Okay. So that already for S now. I said work and can think of intraperitoneal or retroperitoneal diseases. Can you see? You check if you can be able to see the gas in the stomach and the bowel, intestines. Look at size and position of the liver and spleen. That's what I have said. Check if you are able to outline the bladder, the urinary bladder, when it is full. Look at the size and position of the kidneys. That is normally lateral to T12 to from T12 to L2, and check if there is clear outline of the psoas shadows. Okay, those are main things you should check for in S. Okay, these and they have drawn on it on this plain abdominal X-ray. You can see the shadow. I've seen it before. The shadow of the liver. You are able to see the shadow of the spleen, the shadows of the kidneys. See where they are. You remember the shadows of major psoas muscles. Should check for them, and even the shadow of the urinary bladder when it is full. Okay, so those are, and even the intestines. Can you see the intestines like a colon, especially the colon, ascending, transverse, splenic flexure, descending, sigmoid, and the rectum. So when you're under S, please make sure all of those structures you check for them. Are they missing? If they are missing, what will be the cause? Okay. For this second one, we're able to see the shadow of the liver here, the shadow of the kidney, right kidney here. I can see the left one is difficult because of this fecal material. The major psoas muscles can be seen, the shadow. The spleen may be, and the inner bladder was empty. Instead, we can see the fecal material in the rectum. What else? You see? For this patient, the patient had a lot of fecal material. That's chronic constipation. Too much fecal material in the colon. That's the sign of chronic constipation. Okay. So, do you understand how we approach the interpretation of plain abdominal X-ray? Remember, for chest X-ray, chest radiography, it's a bit different. Ask, please.
What is this structure look like? Lucent, that is crossing the abdomen, which is horizontal.
Now this one.
Yeah.
No, this one I think it was like a belt or something.
Okay.
There's something that is making a depression of the abdominal wall. Can you see? Maybe there was something that is like belt or something. It's not part of the normal anatomical structures you can see. We are able to see on plain abdominal X-ray. Okay. That's called observation. By the way, radiologists should, when you're interpreting radiological images, you should be careful and see everything, that any change. Okay, that's good. Any other question? Here it's about ABCS. From when you see you have plain abdominal X-ray in front of you, think of immediately approach it in ABCS. Check A for adequacy, alignment, that's technical, and apparatus, if is there any apparatus there. Okay, that's number one. And you go immediately for B. B, remember, it's about bones. Check the bones and the classifications, check them. And remember, for bones, it is clear, check each bone, as you have done for chest radiograph, remember. And classification, please look for them. They can be either in the gallbladder, they can be in the kidneys, they can be in the pathway of the ureters or bladder, bladder. They can be in anatomical in the pancreas. Check if there's some classification for, remember, if you can be able to see the classification of the pancreas, think of chronic pancreatitis. So make sure you check. Don't just let them go. Check them. And then number three is about C. C for cartilage and joint. Check the joint. Are they okay? All joints you are able to see. There are not many, but check. And the S, soft tissues. And in the soft tissues, remember, that's the reason why in a collimation you should even include the diaphragm. Don't miss any free air under the diaphragm. Like in these two images, the collimation was not good. Maybe there was the peritoneum, the cause of that pain. Okay?
Lecture question. What about the collimation? You say that it's not good.
Here,
Like see,
on this one, you want remember on plain abdominal X-ray, what have I said for collimation? What do you have to check for?
check for spinous process and
Oh yeah.
sacroiliac joint.
So you collimation is carry.
Lecturer, we check centering. We check if the diaphragm is included, and even if the is included, and we have to check if here on abdominal, of course, we have to check
pelvis,
down
the pelvis,
there.
especially for the hip joint. Yeah. They say just normal the glowing so that you cannot miss the.
Nyitangije na rotation. Nyitangije na rotation nyine.
Nicyo kibazo cyawe nyine nta kundi ntagira gusese. Nite twavuganaga nzi ko abantu baga ko aribo bafite ikibazo none nabahuye. Can you continue? So biroroshye hano, is it easy?
Lecturer, but I have some confusion. The confusion I have for this systematic approach for abdominal X-ray, we start by ID of the patient, identification of patient, and the second it was ABCS. Then technical details and those interventions are come after ABCS or are the same.
That's a good question. Maybe I confused you, but listen, for plain abdominal X-ray, when you have it here in front of you, check identification first, okay? And immediately you go for ABCS. Immediately you go for ABCS. Because in ABCS, A is about technical, normally. B, bones and calcification. C, cartilage, joints. And A, soft tissues. That's it. Identification, that's number one. Number two, ABCS. Number three, nicyo ngiye kubabwira nyine. Number 3, it's about now how to report. No, how to report. Remember that that's the same for even chest radiograph. Remember, you start by the bigger picture of the image. By the way, that was the next slide. Normally, number 3 is about the most obvious abnormality. That's how we do in radiology, by the way. When you are looking at the image, CT scan, MRI, X-ray, hello. We start by, hello. We start by the bigger picture in the image. You cannot start by the smaller things and forget about big ones, findings, I mean. Here also in the abdomen, if there is abdominal intestinal distension or dilatation, that's the bigger picture. When I'm reporting a SAT, I can see there is intestinal distension or dilatation. And after that, you can go for smaller things. So that's the system, how you interpret. Start by the most obvious abnormality. And number 4, you go through it systematically now. Okay. What I want to see, like systematically, you start by A. A, it's about air black. Remember, we have seen for chest radiograph, A, B, C, D, E, air. And air in chest radiograph is about intraluminal air. Okay. Point is intraluminal air. This one I want to say there is what you call rule of 9, 369 rule. 369 rule. They say normally the small bowel diameter should not go beyond 3 centimeters. And large bowel should not go beyond 6 centimeters, that's diameter. And the cecum, 9 centimeters. When they are beyond, you think of dilatation. That is 369 rule we use. But normally, if you have a normal, a picture of a normal anatomy of intestines, by just looking, you see, there is a dilatation of this small or large bowel. That's number 1. That's about the size.
About that centimeters means that cecum has
It's big.
more centimeters than small bowel.
Not even cecum senich. It's part of what? Akanatomy wibagiwe ka anatomy ho gakeya. Ntuzi ko cecum ari nini cyane kuruta n'ibindi byose. Cecum ntawe uzi ko nini cyane? In diameter.
Ni uburebure cyangwa ni
diameter. Abivuze. Diameter.
Yeah.
Cecum is bigger than even the cecum. You know that's part of the colon, the large bowel. Urabyibuka sibyo?
Yego.
So that's the bigger part, diameter, in terms of diameter than. Now uravuze length, navuze diameter.
Okay.
So the differentiation normally it's about the size. The small bowel is small in diameter, large bowel is bigger, but cecum is the biggest part of the intestines in terms of diameter. But also there are some other differentiations, like small bowel within on plain abdomen, abdominal X-ray. There are some what you call valvular conniventes. There is the valvular conniventes on plain radiograph. You can say this what I am seeing here. These are small bowels because they have what you call valvular conniventes. Those are folds. Those that are continuous along the whole diameter of the bowel. Valvular conniventes. Those are not anatomy. They are folds that are crossing the whole diameter of the bowel. And again, the small bowel are central located in the abdomen. I'm trying to show how we can differentiate large bowel and small bowel on plain abdominal X-ray. Number one, the size. Small bowel is small. Number two, small bowel, they are located centrally in the center of the abdomen. And number three, they have what you call valvular converters. Those are folds that are crossing the lines that are crossing the whole diameter of the bowel. But for large bowel, first of all, they are large, as I said. Number two, they are peripherally located. That's anatomical, normal anatomy. And number three, the folds they have, they are called hostry or hostrations that are not crossing the whole diameter, but they are crossing only 1/3 of the diameter of the bowel. This is very important, by the way. In the case of intestinal obstruction, you remember interpretation, you should tell this is small bowel obstruction or large bowel obstruction. How do you recognize them? How do you know them? By this, by the size, by the location of the bowel, even by these hostrations, hostry cyangwa se valvular converters. Very, very important. Okay? Nizira ko mubyumva ariko murabyumva neza mukanya on the images. And number two, they are trying to say about the air in the abdomen. If you can see, for example, some air or gas in the wall, intramural, in the wall of the bowel, think of ischemic colitis, especially ischemic colitis. Or there are some other diseases like for neonates, you can have neck necrotizing enterocolitis. I will see it later. There are some other pathologies where you can have air in the middle, in the wall of the colon or the bowel loops. And extraluminal, now think of first of all pneumoperitoneum, but also we can have a biliary tree air. Biliary tree air, think of intraluminal infections. And under the diaphragm, think of pneumoperitoneum. Pneumoperitoneum can be either pathological or can be there after surgery. Remember, always you have to correlate with the clinical history of the patient. Free air in the peritoneal cavity can be either pathological or due to surgery or any other procedure. Yeah, any other procedure that can put some air gas into the peritoneal cavity. So for air, so you have to look at air into three things. Either is it intraluminal, and intraluminal differentiate the small bowel and the large bowel. Intramural, the wall, think of infection, ischemic colitis, or and the extraluminal, either in the biliary system, still it is about infection of the GIT infection, or free air under the diaphragm, think of pneumoperitoneum. Okay, free air in the peritoneal cavity. Okay, do you have any question on this one? Because the rest will be based on this, please. Any question of here on this slide? If not, it's better for me because I will go faster.
Question.
Yes.
I do not understand the valvular connivance of the small bowel.
Bavuga valve convertens. Nkuko byanditse in Kilatini. Abize mu seminari aho ngaho. Valvular convertens. Those are folds. No, anatomically, it's the normal anatomy. Folds within the small bowel. They are called like that, the folds. On plain abdominal X-ray or radiograph, we see them, the lines crossing the whole diameter of the small bowel. Okay, that's a normal anatomy, by the way. But for the same folds for now large bowel, they are called the hostulation or hostile. Or hostile, the way you want. That's what hostile. Call it Latin. So those ones now, they don't cross the whole diameter. They just involve the 1/3 of the diameter of the bowel, large bowel. Nibitandukanya ibi, those are normal anatomy. Itandukanya the small bowel and the large bowel. Apart from those two,
Okay.
we consider the location of the bowel and even the size. Okay.
Okay, thank you. Yeah, thank you.
Any other questions? So, or I go to next slide.
Let's go.
Let's go. Okay, good. Here they just want to insist on what you have to check for in S. Remember ABCS. Okay. Listen, reka nitaba umuntu gatoya, just few seconds. Nitaba umuntu gatoya nyuma. Akamba. Hello. Sorry for interruption. Hello. Are you still
Hi.
there?
Yes, yes.
So under S, here you remember I told you under S, A, B, C, S, under S soft tissue, intestines, bowel loops are within them. So like now, here they want just to differentiate the small bowel from the large bowels. In terms, you remember, we differentiate them in terms of size, location, and using valvular conventers or hostry. Like for these ones, even if the small bowel are dilated, if you are able to measure them, there will be more than 3 centimeters for sure. But also they are central located. When you say center, it doesn't mean something that's cannot reach the periphery. But like in this dilated bowels, if I want to locate them, I will say they are central located. Remember, even if they can reach the periphery, but most of part of them, it's the center. It's from the center of the abdomen. Okay, and peripherally, you can see these lines. There's someone who asked me, valvular conventers, what is it? Can you see these lines? These lines are crossing the whole diameter of the bowel. When you see them crossing the whole diameter, I immediately think I'm very confident and sure that these are small bowels. When they can only cross the 1/3 of them, of the bowel loop, think of like in this case, all they are crossing the whole diameter. They are crossing the whole diameter. This is a small bowel, but we will see where they are now, they can involve only the third. In that case, it is a sign of large bowel, and they are called host illustrations. Okay, that's what I wanted to tell you on this image. Tell you about valvular conventers, sign of small bowel, and hostry. Even if you don't see the hostrations, because the large bowel is these are small bowel dilated. If valvular conventers, the large bowel is part of it is here in cecum, part of the cecum. The ascending colon may be here. The transverse is covered by the small bowel, that is the dilated. The descending, you can't see it. This is that part of the rectum. We'll see. This is pathological X-ray. That's what you can see. Okay. Any question here? So when in diagnosis like this is small bowel obstruction, because the small bowel is dilated, I'm very sure that this is small bowel because it is centrally located. They have valvular conventers within them, and the large bowel, it's collapsed peripherally. Small bowel dilated, but the large bowel is collapsed, meaning this is small bowel obstruction. Okay. So let us now go to large bowel. Can you see? Even the large bowel is dilated. It's more than, they said more than 5 centimeters. You remember that they say 3, 6, 9 rule. More than 6 centimeters. It's very dilated here. And when you look at them, these ones you see, you can see the folds are now across the involving 1/3 of the diameter. Estimation 1/3. And when you see this dilated and 1/3, they are not valvular conventers. They are hostly now, hostrations. Okay, hostrations. Okay, and again, they are peripherally located.
Lecture, we are not listening to you.
Hello. So the network had gone. I didn't really organize. The network had gone. Now mwacecetse ntimwavuga. Mwavuze? So network itarimo ntabwo nakumva. So sinarizi yuko mutakurikiraga, nakomeje ndavuga jyenyine nabizi nanjye ko yagiye. But let me repeat what I said. Umuriro wagiye iragenda sinabyitaho ko yagiye. So twari turi hano. Can you see my slide?
Yes.
So twari turi ahangaha. I was trying to compare, you remember this previous image for the small bowel, what we look for, so that we are able to see, to call it small bowel dilatation. But for the second one, it's about large bowel obstruction. I told you that's first of all, the bowel loops we are looking at, they are dilated. That's number one. Number two, it's about the location. They are peripherally located. I was telling you the anatomy. I don't know if you could hear me. This is the cecum here at right iliac fossa, ascending colon, hepatic flexure here. I told you that the transverse one is, they make a U shape. Normally, the normal anatomy it's like this. To go to splenic flexure, the descending one, ascending colon, sigmoid and rectum. But what I was telling you, we have already seen two, dilated bowel. Number two, the location, that is periphery. And number three, within them, they have what you call hostry. They are no longer valvular conventers because they are not crossing the whole diameter. They are just involving 1/3 of the bowel. So those are the hostrations or hostry. And those are the three signs of large bowel. It's large bowel, it's no longer small bowel. My question is, can you differentiate these two images? Can you recognize small or large bowel on plain radiograph? Hello?
Lecturer, in terms of conniventous and the hostria. Yeah, it's difficult for me.
Oh yeah, difficult how? Can you see this? Don't you see that? Listen, don't you see that? Remove your mic. don't see that they are crossing there's very thin lines that are crossing the whole diameter. Can you see? They are crossing the whole diameter of the bowel. Everywhere they are crossing the whole diameter of the bowel.
Let's see hostry.
Aha. Hostly, look. Those are hostly. Those are hostly. Those are hostly. Even this one, what is part of it is not crossing and reach there. Even here, this is not crossing the whole diameter to reach there. No, it's just part of it. 1/3 by estimation. Can you see the difference? And again,
Yes,
in radiology, never say it's difficult to see. They are always they are difficult, yes. They are difficult, but that our role now to see those difficult things to see. They are not easy to see, I know. But and again, something I didn't mention, for the small bowel, the wall is very thin. Even these valvular converters are thin lines. The wall is very thin and smooth and thin. But for the colon, the hostrations are thick. That's number one. Even the wall, colonic wall is thick compared to the small bowel. Okay? Birasobanutse?
Yes.
For this is now, if you understand this, it will be for you easier to diagnose any bowel distension, bowel obstruction. You will recognize them very well. Savior. Okay. Can I continue?
Yes.
yes, for sure.
So, S, we are still under S. I'm still trying to show you what you are supposed to look at under S. Remember A, B, C, S. A, adequacy, alignment, and apparatus. B, bones and calcification. C, cartilage and joints. A, soft tissues. So we are under S. We started by intestines, large bowel and small bowel. And now we are still under S, soft tissue.
Lecturer, I can't hear you.
Hello, can you hear me then?
Yes.
And put the phone. I was on phone. I'm using now my phone. Before I was using internet, home internet, but now I'm using my phone because nta muriro uhari. So nibahamagara birajya bikupa gatoya ariko ntabwo ari kenshi. Okay? So they want just here to show the shadow of the major psoas muscle. Like on the left side, remember, we should see them when you miss something you are supposed to see as you are interpreting the plain abdominal X-ray, always remember to you have to look to search the solution. Why aren't you able to look at to see that structure, that shadow? If it is about kidney, why aren't you able to see the shadow of the kidney, the liver, the spleen, the major psoas muscle, the intestines? Like in this case, we are able to see the left major psoas muscle very well, but the right one you don't see it. Sorry. Okay. Sorry. Sorry for that. Can you see my slides? Oh,
Yes, Rector.
Yes, Rector.
which one? The one we are looking at?
No, the next one, systematic interpretation abdominal. Different.
Okay. No. Okay. We are here. See you.
Yego.
Aha. So we are the right side. We are not able to look at to see the shadow of the major psoas muscle. And immediately when you see this, you should ask yourself why there's something wrong. And in most of the cases, we know it can be psoas abscess, it can be ascites, can be any different pathology that can be mass, tumor, abdominal tumor. But when you miss something like this, you always have to look for the reason behind. Okay. So again, I told you under S, you look for the diaphragm. The diaphragm is part of, remember, it's part of the S, soft tissue.
Okay.
Diaphragm especially. Yes, a question?
No.
Yes, the diaphragm should be included in the film because you are supposed to check if there is no free air under the diaphragm. And here I want to say something. When you have a patient, a very sick patient in your ward, and you send the patient for plain abdominal X-ray, and immediately the patient has been lying down, and let us suppose that the patient has pneumoperitoneum, free air in the peritoneal cavity, and now if the patient is able to stand and be taken a plain abdominal X-ray film, don't think that free air will go up immediately. Sometimes you can miss the pneumoperitoneum because of the technique you have used. They say it's better to ask the patient to change the position from lying down, maybe being seated for some time, for some minutes, before you do abdominal or chest radiograph for you to diagnose the pneumoperitoneum. Because you have to give some time, for minutes, for that air to go up so that you can see it under the diaphragm. Otherwise, you can miss the pneumoperitoneum. What do you say?
Yes, but approximately how many minutes?
But yeah, few minutes. Just don't just tell the patient when you suspect pneumoperitoneum and the patient has been lying down for long. Don't just send the patient to the, but this is especially for technician in the radiology. Don't just tell the patient to stand up, immediately take a film. You can miss that free air. It is still down, and you miss it. You say it is normal while there is pneumoperitoneum. Just a few minutes for that air to go up.
Clear.
So here you can see, and again, if you suspect pneumoperitoneum, it's better to request for chest radiograph than abdominal X-ray. So chest radiograph is more sensitive to detect that free air than abdominal X-ray. That's another information I wanted to give you. Okay.
Okay.
So, so in the under S still you have to. They say they have put cartilage of ribs. They put under S soft tissue, the blood vessels. You have to check if there is anything like an aneurysm. You can still diagnosis under S soft tissue. Pancreas. You see, kidneys, right upper quadrant for gallbladder, caliculi. Those are under soft tissues. So, who can help me? Who can look at this abdominal X-ray? Who can systematically, the way we say it, who can approach this? Who can interpret this? And just one person can just come and say, this is plain abdominal X-ray, and he tells us what it is until he gives the differential diagnosis here.
Let me try.
Try, please.
Yeah, about this abdominal X-ray. Adequacy of this ray, I see that it's good because I can see the spinous process. Yeah. And
adequacy. That you start by A.
Yes, adequacy. And the
always remember, even for chest radiograph, always when you are taking a technical, start by centering collimation. Always start by collimation.
Okay, yes.
Always.
Sure. Yeah, about coordination, I see there is some problem. Because I see that the distance from the left sarcoiliac joint to the somehow.
Ayo magambo yabananiye kuyumva rakora amagambo asanzwe yoroshye. Collimation is umva nk'icyo.
It's centering.
Yeah, it's something new.
Yeah, it's centering wrong. Yeah, but
mwayifashe ari radiology ari nk'igishinwa somehow. Ni amagambo asanzwe. It's something ni isanzwe n'icyongereza gisanzwe by. Mugize amagora ibindi bintu bidasanzwe. Kuki mugiye mubyitiranye no kubera iki ijambo risanzwe centering collimation centering ni ijambo risanzwe.
Yes. Lecturer, about the collimation, there is somehow problem because I can't see where the under diaphragm.
Exactly, the diaphragm is cut off, meaning this is a problem. This is a problem.
Yeah. Yeah. And also the whole pelvis, I can't see it because
the pelvis is okay. The pelvis you are able to see the heads, the femoral heads. That's okay.
Okay.
Because our intention for abdominal egg normally, even for chest, when you do chest radiograph, in most of the cases, it's not about the heart. It's not about it's about lungs normally. That's the indication. It's lungs normally. For abdominal X-ray now, the intention is not about bones. The intention about bowel loops, I think, abdominal cavity. Okay, so we don't have to have all pelvic bones in. Okay.
Yeah. About penetration is good because I see the spinous process.
Spinous processes,
yeah, very visible, and some internal organs, soft tissues are seen. Yeah, About rotation, I have said that it's a bit related because I said that the distance from the left sacroiliac joint to the spinous process is somehow
Sacral, not psycho.
yeah,
Sacroiliac.
yeah, sacroiliac joint is a bit larger than the right one.
Oh yeah, no, it's about distances. The distance
Yeah,
from here to here and from there to there, are they different really? The same. It's by estimation they are the same. There is no rotation here. Since ko
okay.
mwabyumvise ugashaka kuba mutabyumvise neza.
Yeah, about inspiration is good because it's not too wide, it's not too dark.
Numva mu cyubahiro. Nakubwiye ko ndi kwigisha none mo murampamagariramo kandi nabibabwiye kandi bita bivanaho ibintu byose di. Niyo mpamvu nabwira ngo please mukoreshe SMS byari kumfasha kandi ngenda asubiza nta kibazo. Ngaho mbwira nta kibazo ariko nyine. Ryikise. Irisanzwe. Bindi bikora. Buriya. None turabigenza gute ubwo? Ubu ntabwo bikenewe. Sorry. Nese bimwe yashakaga mbere avuga ngo ntabwo yabibonye aho ni hamwe biboneka ntabwo babona ahandi. Bimwe byagwaga mbere. Reka sha. Yabajije hamwe yabajije hamwe. Oya none se ikibazo oya. Nyine nicyo nshaka kubaza kuko ntabwo wakibona ahandi se. So dukora iki mfata umwanzuro unyandikire message ariko. Sawa okay. Can you hear me please?
Yes.
Nababujije bano bantu ngo ntibampamagara ariko barampamagara yewe. Okay, so continue please.
Yes, we are done with inspiration. Inspiration is good, as I have said.
What?
Yeah, inspiration. It is taken in deep inspiration, is what I said.
Inspiration?
Yeah.
Yo munda se?
Yeah, what about inspiration, lecturer?
Mbona mushyizemo ko kandi akazi kanyu mushyizemo ko radiyo ari ibindi bintu bindi kandi bisanzwe. Inspiration uyikuye ko atari igishinwa turi kuvuga. Inspiration ije gutse ivuye no listen. Ibintu kwigisha biragoye se nzaga ibintu bisanzwe byumvikana. Ubona urubuga no kubivanga kandi ari ibintu byoroshye rwose. Abdominal X-ray tureba ibintu bitatu. Turi neza, start by collimation cyangwa centering. Twayivuze tukareba ko penetration imeze neza kugira ngo ifime yacu itaba iri black cyane cyangwa white cyane kamisinga some findings. Icya gatatu tukareba niba ari symmetry hatari rotation. Ibyo byonyine biri tureba as technically aribyo bisimbura A adequacy, alignment and apparatus. Nk'ubu hano hari apparatus aho kumbwira ko irahari. What do you think this is? It's an apparatus. Mwamuzi apparatus yari cyo. What do you think this is?
It's catheter
Where is it?
to the urinary bladder.
And this is a brother here.
No, at the rope.
Hey.
From the kidney to the
brother, kavuga ibane batsa kugira hano ngira ngo simbizi. Reka mujye musubiza neza mu byuzuye.
It is through the ureter.
Through the ureter. Okay. So that's an apparatus. Nibyo twavugaga A. Noneho uriya muntu abaje gusubiza tugende kuri B. Aricyo bitwaye si ibintu byoroshye. Mwabikomplitse kandi byoroshye. B. Go to B.
Yeah. On B, I see the bones. Bones are well because I see that no problem I have found it because the joint of
B ntago harimo joint. Nyamuneka mujye ukamabwira rero.
it's a bone.
Radiology it's about system. Ibyo nababwiye follow the steps. Nta kintu.
The bones are okay. Yeah, joints are okay and no
joints twazivuze tubazigereho. Turi under
I'm
B.
saying bone. Yeah, bones. Bones
Bones
are okay. There is no classification I see.
Washakiye classification. Me I can see some.
You can see some.
Nonse kupfa kuvuga utabirebye kukigiye kwitegereza no kutari babirebye neza. Where to look for them? Check where the location of the gallbladder. Is there any classification? The kidneys. Is there any classification? The ureters. The bladder. The pancreas up there. Should check for them. No classification, I agree with you, but now I will systematically. Continue.
Let me see where.
Abantu mwegeranye bafunge mic zabo. Ntago yawe yasakuza gutyo. It can't. Hari umuntu wundi wayifunguye ibyo ni ibintu mumenyereye I think. Kugira ngo hazemo icyo gisaku nuko hari umuntu wayifunguye yindi.
Lecturer, I can't be able to find the classification. Let me continue.
There isn't, but I wanted you to check for them systematically. You should remember where to look for them.
Yeah, let me go to cartridge and joint. Let me go to cartridge and the joint.
Where do we look for them?
Where
do we look for them?
Ufite ikibazo cya network I think. Cyangwa niyo gifite kugenza teko nayifite cyane. Navuze yuko kuva na mbere ariko it's not just now. We look for them. Where do you think abnormal calcification can be in the abdomen? It can be in the gallbladder. And the liver is here. The gallbladder is under the liver. Check if there is nothing. Check in the kidneys for caliculi. The kidneys shadow, you know where they are located. Bilaterally, check the pathways of the ureters, because you can have ureteric calcifications. It takes stones, both sides. Check in the bladder, and also check in the pancreas. And you know anatomically where the pancreas is supposed to be.
Yes.
And remember, there are some normal calcification. Remember what I told you? There's when you are reporting abdominal X-ray, you say there is no abnormal calcification because we expect to see some normal calcifications, like in the vessels, aorta especially, and the spine. vessels and spine, you can have the normal classifications. Abnormal ones, then the gallbladder, kidneys, pancreas, ureters, and the urinary bladder. Okay? Kabivuze kenshi umusubiyemo nka gatandatu. Either you have a network problem or cyangwa kindi kibazo gikomeye.
Lecturer, can I continue?
Yes, please.
Yeah, about the cartridge.
And joint.
Sensory, I can't see where. Let me say joint.
Do you know? No. Aho ngaho nimwahumvise nahise mbyumva. En fait, imba nibwira yuko iyo ndi kuvuga niyo kandi abivuga byose mba nabivuze. Ariko you don't capture the message.
Nabitubwiye nabyumvise.
Impamvu bashyizemo cartilage. Do you understand?
Yes.
Impamvu bayise cartilage and joint nuko bashaka ikintu cyasa na C. Bashatse ikintu kiri ABCS, ikintu gisa na C. Otherwise it's about joints. Nibyo nakubwiye. Naho cartilage ntabwo wayibonera kuri X-ray. Bashaka izina ryajyamo C, cartilage and joints.
Okay. Sacroiliac joint on the right side, on the left side, please. It's not as smooth as the right one.
It is. Look, this is the joint here.
Mm-hmm.
It is the same as the, okay. That's because by any, remember the bowel loops with fecal material, especially the colon, can over impose to other structures. Uzabireba cyane usanga bowel loops zahinda. Exact. For example, here, can you see this? I think this is the cecum.
Yes.
If you don't know, you can say there is bone iliac region, iliac region here. But we know this is the cecum, here in the cecum, superimposed to the bone. The same here now, some different structures can be superimposed and change the way you see them. Maybe there was a small rotation making it not looking like, so it should, that's how we interpret things. And we applied that even for chest radiography. Remember, before you say there is a problem, check very well if there is any cause. Continue.
Yes. About the head of the humerus, this is a stabular on the lecturer. There is no problem on the right side.
There isn't. They are normal. Okay, the same. It's about positioning.
Okay.
But okay, it's good that you remember to look at them. Maybe you don't have much knowledge about what's normal, what's not normal, what's not normal. But the most important thing, please remember to check each joint before you conclude. Okay. And
let me go to soft tissues.
There you go.
Yeah, about soft tissues, I see some problem you have said is about this cecum. Yeah, I see that's become bigger, the cecum, and also I can see ascending colon. Yeah, above the cecum. It it's clearly seen. I don't know if it's the problem of the illustration too. And I can see the transverse one and the about fracture, splenic fractures of large intestine also seen. And I don't know if it's normal because for me I see that it's abnormal.
Okay.
Yeah,
What
and I
else?
can see urinary bladder is clearly seen also.
Exactly.
And
The inner bladder is full. Here you can see the shadow.
yes, I can see the shadow,
Mm-hmm.
but I can't see a river shadow well.
It is. It is. First of all, remember cremation. You are supposed to want to see an abscess in it or a small. You can't see. Yeah. Uh-huh.
And yeah, small intestine. I don't see small intestine.
Small intestine is normally. Listen to me. I hope people are following. Kandi yo nakazi kanyu muzatsindwa radiology musubire mugira ngo ni imikino. Small intestines normally they don't have air. Mubizi, that's normally.
Yes.
They don't contain air or gas. The gas is seen in even fecal material in the colon. Normally, the small intestine, when they don't have any problem, they are concentrated in the center, and you don't see them really on plain abdominal X-ray. You don't see them as bowel loops unless they have a problem. What you the colon, ascending colon, transverse here, you can see this transverse, splenic fracture, descending, and rectum. And here, some of the bowel loops appear to be enlarged because of, can you see this fecal material? They're not to be seen this way. There is much fecal material. This is a case of constipation. That's the reason why some of the bowel loops are dilated because of this study. The fecal material is not coming out easily. It has been there for some time, and now proximally they are somehow dilated, but it is not intestinal obstruction. It's not intestinal obstruction, because intestinal obstruction, maybe we'll discuss about it. We'll see many images here. They are indicated by something else. Okay.
The last three is about psoas
muscles, major psoas muscles. Right side is here. Can see it here. The left also is there, but it is superimposed with this air-filled colon. But it is there. The shadow is there. You see? Ntabwo radiology tureba ibigaragara cyane gusa turabireba tukamenya ko bihari cyangwa radiology ni ikintu kimeze. Radiology ugerageza kureba ibyihishe nyine. Niyo nature yayo. Niyo nature yayo rwose.
Question. Tugarutse gatoya kuri C. Cartilage and joints. Ko mbona area of sacrum yo kuri left imeze nk'aho ifite aversion fracture gatoya.
Hezi ko yenye ubona neza yose. Left side ni iyi?
No. Area of the sacrum.
This one? Uravuga hano?
Yeah.
No. This is a line. Listen, the line that is continuous like this one. Okay, it's good to notice that, but this is a continuous line like this, but there's no fracture here. But it's good to see that. It's good to think about that. Unugutangira kugira amaso nk'ayo mu radiologist. You see many, but you accept few.
Okay.
Iyo line ni iki so?
Yeah, just urazi, this is just it's just the position of the patient, the structures that's passing there. Even the bowel loop can give this kind of things.
Okay.
Icyo nababwira gikomeye cyane muri abdominal X-ray, many structures are superimposed and they can give you another appearance, another abnormal appearance where they are normal, because many structures are superimposed, especially the bowel loops and other structures. Ibyo ugomba kubishyira mu mutwe cyane. Any other question before you continue?
No question.
Lecture. Question. You can summarize for us a little bit how to approach this structure like in 2 minutes, just systematic, so that
Which structures?
This one, as we have been discussing about it, but you can go through it as someone experienced it, so that way.
I mean, I don't get the question.
I'm just requesting to summarize for us how to go through systematic way of.
Oh, okay. It's very simple. It's very simple. When you have, when you have a plain abdominal X-ray in front of you, plain abdominal radiograph, it's better to familiarize you to talk about radiograph, not X-ray. The first thing is about identification. That's number one. Ufite notebook wa kwandika identification. Kandi in identification, we know what to look for, and you know the value of identification. Number two, you follow ABCS. A, it's about adequacy and alignment in the apparatus. Adequacy is about technical. We look for collimation. And for collimation, remember, you have to check for the diaphragm should be in and the pelvic bone should be in. That's very important. Like in this case, they have cut off the diaphragm. You can miss some pathology, especially pneumoperitoneum. So diaphragm should be in. And still for adequacy, if you check for the penetration, it's good here because you are able to check to see the spinous processes. And for symmetry or rotation, there was no rotation because the distance from the spinous processes to the sacroiliac joint on the left side and on the contralateral side, they are almost the same. So there was no rotation. That is for adequacy. A, adequacy and alignment. And apparatus, you have seen the ureteric catheter here. Okay, nothing else. That's for A. For B, it's about bones and calcification. Bones, I check the bones, the ribs, we can see in the film, the ribs are okay, there is no fracture, there is no pathology. The spine, it's good. I don't see any problem. The pelvic bones are okay. I know what this is. I know that's bowel loop area, because in bowel loop, in the second, bones are okay. I don't see any bone lesion, any bone pathology. Now I go for calcifications. In B, there is bones and calcification. And the calcification in the abdomen, abnormal calcification, nowhere to look for them. The first one, I look for the gallbladder. I don't see any abnormal calcification. I go for the pancreas to see if there is any chronic pancreatitis. I don't see any calcification. I go for both kidneys. I don't see any calcification. Okay, I go for ureteric pathway to see if there is any ureteric stone or calculus. I don't see any. And for the urinary bladder, I don't see any calcification. That's B. I'm done with B. I go for C. C, it's about cartilage or joints. All joints, starting even for the spine. I don't see any narrowing of intervertebral space, disc space. The sacroiliac joint, I don't see any problem. The hip joints, I don't see any problem. If they had included the pubic bone, I should have checked, but if there isn't, no problem, it's not my problem. But for the joint, I don't see any problem here. And I go for S, for soft tissues. The diaphragm is not in, that's a problem. Either if I suspect any perforation of gut, I should repeat the X-ray. If there is no much suspicion of pneumoperitoneum, I just can interpret still the way it is. I go for liver. I don't see any enlargement of the liver or spleen. The kidney shadows are okay. I see the psoas muscles are okay. The urinary bladder is good. I go for now intestines. Because intestines, remember, they are part of S, a soft tissue. I check peripherally. I can see the cecum, the same colon, but in the same colon there is a fecal material. That's too much for a normal one. The transverse one, there's some fecal material, splenic fracture, descending, sigmoid, and rectum. And in this, what I can say, there is just fecal material that is too much abnormally impacted fecal material. This is a case of chronic constipation, nothing else. That's how I approach this X-ray.
Thank you very much.
Okay, good. So asigaye iminota 5 kwa kundi mukunda kuri bya saa sita zitarenga iminota mikeya nabizi. Ariko reka mvuge kuri aya no oya ahangaha nabangiye muri byinshi. So reka tuhagarike ahangaha. So we come back at 2 then, sibyo?
Yes.
Because you have to finish this. Ntabwo ari byinshi cyane, mu minota mike turaba tubirangije. Hanyuma we see some cases and we go back to the chest X-ray. Aya cases yari asigaye tuyarebemo vuba vuba twirukanka turangize nta kintu, nta bindi byinshi.
Iki nicyo tuvuye.
So at 2 we meet at 2.
Yes.
Mugende ibyo byanyu bya saa sita ntibibacike. Ndabazi n'inzara zanyu. Okay? So see you at 2.
Yes.
Thank you.